So good morning, good afternoon, good evening. Welcome to the 717 Global Learning Network webinar. Today, we're going to be speaking about how cities can use 717 to strengthen health emergency preparedness and response. To start with, some housekeeping. So please add your questions to the question and answer box. We will address them during the Q&A portion of the webinar. The webinar will be held in multiple languages. Please select your language, English, French, Spanish, or Portuguese, and join the relevant audio channel as needed. I want to highlight, please select the English channel if you're listening in English. If you have any difficulty identifying the location, please look for a button with more, and then you'll find interpretation. Automated captions are also available in your meeting controls. Next slide. As I mentioned, we will be talking about the use of 717 in cities. Cities are an important feature of human civilization. And cities concentrate people, which means it might be easier without preparedness for diseases to spread from person to person in cities. And as we saw during COVID-19, cities were badly hit by that pandemic. But cities do not only concentrate people, they concentrate resources, they concentrate ideas. And by putting this together, we get innovation, and we're able to put in place measures to mitigate the impact of outbreaks and epidemics. Today, we have a wonderful lineup of speakers who will be talking about 717 in cities. We are very, very delighted to have the Big Cities Health Coalition join us today to give introductory remarks, but also co-moderate these presentations today. And our special guest from Big Cities is Kate Donaldson. Kate is the Senior Director of Programs at Big Cities Health Coalition, where she oversees the program's portfolio. Kate facilitates capacity building and sharing of best practices among the member cities of the coalition, and she synthesizes learnings for partners. Prior to joining Big Cities, Kate served as the Deputy Director of the St. Louis County Department of Public Health, and we're really delighted to have her with us today to give opening remarks. Kate, you're welcome. I will remind you to speak a bit slowly to allow our interpreters get the translations out. Kate, you're welcome.
Thank you for the introduction. Like Mohammed said, I'm Kate Donaldson, Senior Director of Programs from Big Cities Health Coalition, and I'm happy to be here. Next slide. So Big Cities Health Coalition is a forum for the leaders of America's largest urban health departments. We exchange strategies and jointly address issues to promote and protect the health and safety of the more than 61 million people they serve. Together, these public health departments directly affect the health and well-being of about 1 in 5 Americans. So here on this map, you can see our 35 member jurisdictions. We cultivate direct relationships with lead health officials, one of which is speaking today, by enabling timely information sharing and coordination among and across member health departments to enhance situational awareness and response. Next slide. Big city health departments, including county departments that serve big cities, are on the front lines of preventing and responding to public health emergencies, including natural disasters such as fires, floods, earthquakes, and pandemics. Local health departments help build resilient communities by preparing for these emergencies and supporting residents recovering from them. Next slide. Despite the increase in emerging and re-emerging infectious diseases and weather-related, environmental, and other emergencies, preparedness funding has decreased by over 30% over the last 2 decades. And then, of course, in the current policy and funding environment, those cuts have and will continue to increase significantly. Under the continuous barrage of wide-scale public health emergencies, such as the COVID-19 pandemic, Mpox, and measles outbreaks, health departments are constantly doing more with less as the public health infrastructure struggles in the face of funding and policy threats. With these challenges, effective and efficient public health response is more important than ever. Our members are looking for ways to improve workflows and coordinate with partners to respond quickly to outbreaks and threats. The 717 target allows health officials and program staff to rapidly identify system-level bottlenecks for timely detection of outbreaks. Notification and early response help staff to find solutions to address them. The best part, many of these solutions are inexpensive and quick to implement, such as some workflow and coordination improvements, or long-term system investments that should be prioritized for future funding. Next slide. This chart illustrates how emergency preparedness funding has dropped off as the pace of health emergencies has increased, highlighting the importance of funding, but also the need for quality improvement efforts for public health response. And then next slide. We look forward to hearing from the jurisdictions today, and especially one of our members, Pima County Health Department. Thank you.
Thank you very much, Kate, for that wonderful introduction. If you have any questions for Kate from Big Cities, please put it into the chat, the Q&A box, and then we'll get your questions to her during the question and answer session. Our next speaker is Dr. Theresa Cullen. Theresa is the Public Health Director in Pima County, and she became the Public Health Director in May 2020. She successfully guided the county of over 1 million residents during the COVID-19 pandemic. She developed local public health data modernization initiatives. She initiated and integrated a data analytics team and focused on community engagement, human-centered design, and public health data sharing. In addition, she has developed a strategic approach that is being used for transformational health status change, with the goal of helping all residents achieve health equity. Theresa, we're really delighted to have you today. Please go ahead with your presentation.
Welcome everyone who's here. I am so appreciative of the opportunity to have worked for the past few years with 717 because of the transformation it's been able to provide to our county. So today I'm going to talk about that experience. Next slide. Because we live in an area where our tribal nations are critical members of the work and the population we serve, we do honor them, and we do this with an Indigenous honoring. I will just read the initial part of this. On behalf of our Pima County residents, we honor the tribal nations who have served as caretakers of this land for time immemorial, and respectfully acknowledge the ancestral homelands of the Tohono and the multi-millennial presence of the Pascua Yaqui tribe within our county. For reference, both the Tohono and the Pascua Yaqui tribe are cross-border tribes. They both maintain historical lands as well as populations between Arizona and Mexico, especially in Sonora, Mexico. Next slide. So today I'm going to talk about how we use 717 to help transform our response to outbreaks, as well as contribute to a deeper understanding of how the data that we were able to collect and evaluate is contributing to our commitment to be a learning public health system. We will share with you information that we gleaned from how we responded to multiple congregate care as well as school outbreaks. For congregate care in my community, that refers to any long-term care or assisted living facility. Next slide. Pima County has over 1 million residents, as Kate talked about. The demographic breakdown is here. Our social vulnerability index, which is a number that is calculated based on socioeconomic factors, ranges from 0 to 1. For Pima County, it is 0.88, indicating that we have a highly vulnerable population throughout our county due to traditional socioeconomic factors such as high degree of poverty, lack of access to care, educational opportunities, and other things like that. Next slide. So our first case study will be from congregate care settings. Next slide. So I am hoping that most people are familiar with the 717 metric, but what I'm going to do in this slide is show you how that metric helped us identify major problems we had in response to outbreaks. This information is from our COVID time period, though it is not just COVID. We had 62 outbreaks in 23 in our long-term care and assisted living facilities. And remember, an outbreak refers to more than, in this case, 3 to 5 individuals being inundated by that disease, being affected by that disease. You may recall in the early times of COVID, long-term care and assisted living were locations where individuals were most at risk. Our community suffered significant mortality, meaning death, in these communities. So our ability to respond, to identify through detection, notify, and respond was critical because the impacts were huge in terms of preserving life and decreasing morbidity or the effect of illness. So you can see this is aggregate data. Detection, if you'll recall, the 717 is 7 days, notify is 1 day, early response is 7 days. And you can see what our median was here, which looks like it was good. But overall, you can see our detection of outbreaks only occurred in 74%. Our notification, which was when we knew we had an outbreak and we let the facility know, was only in 34%. However, our response was good. Now, remember, this is 23, and we've already had almost 3 years to increase our ability to respond. This was the very first time, however, we had a metric that we were able to use to indicate and guide us in areas of critical improvement to make sure that our response, detection, notify, and response to outbreaks was sufficient. Next slide. I want to talk briefly about what our response components to the COVID outbreak were. You'll remember that there's a concept called layered mitigation, which means that when you respond in multiple ways to address the different potential causes and ways to mitigate a problem. So here what you see is what resources were available in Pima County for the COVID-19 mitigation. Obviously, these would be different depending upon what your outbreak was. However, there is some consistency here. Knowing PPE, if it's an outbreak that you can test and or vaccinate for with a vaccine preventable disease, using those resources, using infection control, assessment and response, which is a US-based tool, but is highly effective to work with a community and the organization to look at internally what is happening there. And finally, treatment, if that is available, to help mitigate and stop an outbreak. Next slide. So the key takeaways from 23, and the good news is I'm going to be able to show you some better data, is that only 31% of our outbreaks met all metrics. It's critical to meet all metrics. While this was not the number we wanted, having the ability to measure this number meant that we were able to figure out and identify opportunities for improvement and change. The response met the target, as you saw, 100%, and detect and notify were the metrics that we realized we had to pay attention to, that we had to put better processes in place to be able to detect outbreaks in that 7-day period, and notification, which you'll recall is a 1-day period. So as a result of this, we committed as a county, as a city, to work to improve these metrics. We did that through identifying a multidisciplinary department team, as well as working with community and the facilities to hopefully improve that goal and the results. Next slide. So one thing we did, you'll recall, remember, detect and notify, is we worked with our congregate care settings and our assisted living settings, and we set up a regular hosted call. We shared this data. We said it's important for us to be transparent. It's important for us to work with you so that you know why this matters. Remember, at the end of the day, the whole goal is to be able to decrease the impact of any outbreaks that may occur. And this also allowed us to expand our partnership with the preparedness team, which in my county is under the health department, but in a different division. Next slide. So this is where we were last year. We continue to have a significant number of outbreaks. However, you can see fairly marked improvement in the detection and notify. Respond remains at 100%. We are still not where we want to be. We still know that we need to work on detection and notification back to the facility that we have identified an outbreak. However, we continue to work closely with our long-term care and our assisted living facilities and continue to share with them this data. We also make this data available to our community. We use 717 as the metric to evaluate the public health response in Pima County. We are a learning health system, which means we drive decisions we make about investment, whether that be fiscal or human, based on data. What we know is that we are still not where we need to do, where we would like to be right now, and we need to continue to increase our efforts to get there. Now I'm going to transition to a different case study, which is based on school settings. Next slide. We had 375 confirmed or probable outbreaks during an almost 3-year period in our schools. This is a significant number of outbreaks. You'll recognize, I'm sure, that schools are in some ways a congregate setting. Children K through 12 come together from many different communities, many different houses, And in many cases, outbreaks occur in those settings. Those outbreaks have the potential to be significantly impactful because not only do children get ill, they take that illness home to people in their community or in their household that may be more vulnerable. You can see the number of outbreaks we had. We have in school settings, as in other settings throughout the community, respiratory outbreaks as well as GI, gastrointestinal. You can think of this as nausea and vomiting, many cases of these. And you can see this breakdown of what we saw. Next slide. So this slide should look familiar. It's the 717 response in schools. And what you see here, and we don't have the same kind of numbers, but what you see is a range. Once again, you see that in most cases, response is still fairly good, but detection for all school outbreaks can go up to 62 days. GI illness for respiratory, GI illness up to 33 days. So remember, detection is occurring in the community. We, as the health department, may have some insight into it, but we rely on the community itself, in this case, the schools, to let us know what they're seeing. Remember, in many cases, communicable diseases may not be reportable or they may not be obvious early on, which is why detection is so critical. Then notification would be the health department notifying the school that there is a problem, that they have an outbreak. Remember, in many congregate settings, things can look like they're just one incident, and it's that ability to understand that there is a commonality, a common cause there that allows you to detect an outbreak. Next slide. So where are we now? Because we still have a lot of work to do. Even though we've committed to 717, what we're seeing is gradual increase in our ability to meet the metrics. In terms of schools, we're conducting a retrospective analysis of all the data that we've collected. We are adapting the early checklist, the 717 checklist for use in our schools. And we are piloting a notification system. We are calling it VOMIT because GI disease is related usually to diarrhea and vomiting. Obviously, it's not VOMIT, it's virtual outbreak monitoring interactive toolkit to decrease the time to notification and to increase the health department's response in near real time. What we know and what we have learned, and we are incredibly grateful to the 717 workforce, is that we can do this better. And by doing this better, by being able to monitor and work with our community to increase our time to detection and response, that overall we are increasing the protection we can give to our community. And as a result, we can save lives and decrease morbidity. Thank you for the opportunity to present.
Teresa, thank you for the excellent presentation. In 717, we talk about performance improvement and really creating that channel of communication that facilitates the improvement. I was really, really happy to see your congregate call approach, which provided solutions on an ongoing basis and helped to improve overall performance. So congratulations for the incredible work that you're doing. So we're going to move on to our next presentation. I'm really delighted to introduce to you Beatriz Matias da Silva. She is the head of the Center for Strategic Information on Health Surveillance in Recife, in Brazil. Beatriz Matias da Silva graduated in nursing and holds a specialist degree in public health and a specialization in epidemiology from the Oswaldo Cruz Foundation or Fiocruz in Brasilia. She currently holds the position of General Coordinator of Public Health Emergencies at the Executive Secretariat for Health Surveillance in Recife. Beatriz, you're welcome to your presentation.
Good morning, good afternoon. I am a nurse as a profession specialized in public health.
Recife is the headquarters of our pilot project. This is the capital of the state of Pernambuco, located in the northeast region. The territory is approximately 218 kilometers. There's a big territory approximation, about 400 years of history, about 84 neighborhoods, with about 1.5 million inhabitants. It's also the first gastronomic hub of the Northeast. Also the second largest medical hub in Brazil. It's also considered the first gastronomic hub of the Northeast and the second largest hub in Brazil. It's also home to the biggest and largest of the country's tech park, Porto Digital, and it's rich in cultural and folkloric tradition. And it's manifesting in many ways culturally. Next slide, please. The center of the information of the strategies in the state is the coordinator of the public health. It's also known as the CIS. This is services of technology with the strategy to realize extension, notify, monitoring, and the response of the events of the health, that surge emergencies in the health department. It also responds to diseases in events, utilizing the 717 strategy. It also affects the population in various ways in their response. It also helps the prevention to help the public. We also follow a protocol in order to prepare our professionals with the communication. Okay, next slide. So we have been implementing 717 metrics in August of last year. This is about the global. We have been mapping workflows and processes, training of the CIEVS team, also the retrospective review of the 717 metrics in 9 events, pilot of the 717 metrics for 2023, workshop to evaluate the pilot project, revision of the workflows, definition of metric applicability, leadership engagement, and the surveillance network training. And we participate in various events. We applied our retrospective strategy. After this application, we are interested in applicating other strategies to the public health to also take the opportunity to help the public health of our city in our city is one of the biggest events in our city, which is the carnival that we've used the data from 2023. We help a big community of this project in practice. So we have started the pilot project using these strategies in Carnival in 2023. After the application was applied, after this, we realized that this moment was a good moment for the evaluation. So we can see our potentials and any challenges during our application period in real time. And this generated a lot of data to see the good and the bad, and to also define our strategy and reevaluate our strategy practices and the necessity for us to get the data and the response of all of our surveillance team. Okay, next slide. Here we can see an illustration of the application retrospective of our methods during the 9 events that we have highlighted in the process of monitoring. So we can see that, and we can observe that there's 4% that we were able to achieve the response strategy. We can see that there is a lot of room to improve in the cultural response. Next slide. Speaking a little bit about Carnival of Recife. It's one of the largest mass events of the country in various parts of Brazil. This event is about 6 to 11 days of events. There's also 3.5 million revelers in 2025. People in the streets. And this is just from the data from our state of Pernambuco and Recife. So this is a really big event, a mass event. Next slide. Considering this big mass event, the state of receiving in a general form, we need to be able to organize better to organize for our next big event. We're able to monitorize and fix emergency care centers throughout our city. There's 6 emergency care centers, 8 strategic points of free hospital emergency service, referred as SAMU, SAMU. These are ambulance, city, able to monitor better. Also puts 2 professionals at each monitoring point in order to collect the information in real time and to transfer to other 5 professionals located at the central level in order to process and consolidate the information. Okay, next slide. And one of the biggest challenges that we confronted was during this project of the pilots that we're not able to applicate the method to all the people during this last event. So it was needed for us to select any certain events in order to applicate our strategy. This is how we were able to organize to utilize the method in the university. So we were able to applicate the strategies to the outbreaks and epidemics, diseases, ingredients with known causes, changes in the clinical and epidemiological pattern of the known diseases, episodic, the grievances originating from the disasters or any accidents, and any regular products and services. All of these events are registered during our monitoring system of the public health, and we utilize a system in order to monitor to respond to the public health events utilizing the 717 strategy of this event. In order to mitigate these events, are already being reapplied of the 717 method strategy. Next slide. Considering that we need to the engagement, and we were able to get 2 thoughts of the in order to update of the leadership engagement. Firstly is the public health events monitoring and evaluation committee. This is a meeting which occurs in 2 phases or 2 formats. The first phase being with the presence of the executive secretary, managers, and technicians. This with the presence of the 3 secretary, managers, and technicians, where we can discuss ways during the events that we need a bigger intervention to get a second moment, which the second phase is with the presence of the health secretary and executive secretaries. This is in a situation room for monitoring and performance indicators. We can discuss the event and create an action plan for the future. The second phase occurs every 15 days in order to monitor the problem during these phases. The second phase of our engagement period is that it's going to be in 2 moments, in 2 phases. And then these professionals are accompanying with us during our meeting, during our surveillance phase. Okay, next slide. We're able to get across some advances utilizing our 717 strategy. One of them being the creation of a dedicated department for public health emergencies, where our objective is to gather as much data and help as possible. The second event is the establishment and maintenance of a permanent evaluation and monitoring committee in order to create a maintenance project for a permanent evaluation and monitoring committee. The third advance was the 5 parameters for evaluating surveillance performance during emergencies of their response. Before this, we didn't have this parameter where we could evaluate our performance level. Now we do. And having this parameter in advance, we're able to identify the moments that we can direct more help and efforts to help with the efficacy of the response. Our fourth advance is monitoring, detection, notification, and response situations. And then, like I discussed in the prior slide, we have various phases and meetings that we can address these problems. Our fifth advance is to have a stronger integration between epidemiological, sanitary, environmental surveillance, and with our whole primary care team. Our sixth advance is centralized response protocols, plans, and workflow. More directly and exactly addressed of the public mass event of how we respond. And final, our sixth advance, which is the most important, is to increase sensitivity and detecting the public health events in any events. Next slide. Time we were able to observe our evaluation, primarily in the results and our numbers of response. We're able to gather about 79% rates in our results. In 2024, we're able to increase 73%. In 2025, along this time, we were able to increase a lot of good results. And we met about the 79% response rate. We're able to gather a bigger response time. We basically almost doubled the response rate of the event that we've been registering to at the time. Next slide. And also along the time, we also encountered some challenges. These are some challenges we've been registering throughout the time. During the carnival season, it kind of showed us that we're not able to apply the strategy of the 717 for all the events and people throughout the city. So we've been registered about the challenges and how we can better change this. Some challenges are defining the scope of the metric applicability, standardizing concepts, including the event start, detection, notification, adapting the 7 components to the local reality, creating a data dictionary, which includes the 717 method variables, identifying facilitators and obstacles, establishing a permanent dialogue with local management, and expanding the 717 metrics across the entire healthcare network. And with these challenges, we're able to meet our reality of actually what needs to be our response rates to apply this method. Another challenge that we've encountered is to able to better facilitate data in order to consider the other challenges. There were other certain problems that we have encountered that we have included here in the slide of the challenges. We're able to better identify the facilitators of these events before it could happen during the surveillance time. Another challenges is to be able to establish a permanent phase with all the participants during the establishment period. This was one of the big challenges. But we were able to now commit to these challenges to evaluate better. Another challenges that we're still reviewing is to evaluate the methods of the attention of the obstacles at the moment. We are registering of the public health of the Recife of the states, but we're able to gather a good team of doctors and nurses. Next slide. And our experiences at Recife has been very successful, and it's spun interest of our public health. We have about 2 strategies to implement national and Ministry of the Health. which is referred to the CIEVS National. And this in the Ministry of the Public Health is to be able to better implement of the Northeast region of Brazil. The Northeast region of Brazil has a population of about 27% of the region of Brazil, and approximately next near Recife. Also, hiding in the Northeast. We're planning to create a lot better pilot projects and to be able to implement for the CIS network in the Northeast of Brazil. And to be able to better detect emergencies in the North region of Brazil. Okay, next slide. And I want to thank for me being able to present this, and I'm open to answering any questions during the Q&A session.
Thank you very much, Beatrice, for that wonderful presentation. Congratulations to the team in Brazil for the stellar work using 717 at city level, mass gatherings, and also setting that communication channel, that permanent communication channel that allows us to take the information, identify bottlenecks, and then put up improvement actions. Once again, to the audience, please add any questions in the Q&A. We're going to just have a few minutes where we discuss with our panelists. The first question will be to Kate Donaldson. Kate, from the Big Cities Health Coalition's perspective, these are member cities that participate in your coalition. You see 717 being applied, for example, for routine monitoring, of community events or institutional events. We've seen examples of, 717 being applied for mass gatherings. Could be a Super Bowl, it could be a political convention. We've also seen 717 for specific, high threat events. From your perspective and in your engagement with cities, what do you feel is the greatest use case or the most beneficial use case for them?
Thank you for the question, Mohammed. And I'll jump in here. And then also, I think, Teresa can definitely chime in as well from her local perspective. But I think, honestly, the use case, especially when we're seeing reportable vaccine preventable diseases that we may not have seen quite as often in the past, right? Now seeing those appear in our community, the ability to apply 717 for notification and awareness and detection, right? Pretty quickly for even one case, right? Like that's where having it built into the standard outbreak detection is going to be helpful, so that it's not just the large events or big settings like long-term care facilities, but that we also are making sure that our staff are prepared and we're able to detect and respond quickly for things that we're not used to seeing and now have limited resources to respond to. So I think kind of yes, and I believe is the answer to your question, that we need to be able to use this in many different settings so that we can be the most efficient and effective we can with a limited staffing bandwidth and new diseases showing up in our cities.
Thank you very much. Our next question will go to Pima County. Teresa, there were two questions. I'm going to try and merge the thought. How do you really engage? What are your best practices to get buy-in from health department staff implementing 717? And I'm saying this because there was another question that was asking about, what would trigger, for example, a non-communicable disease program, maybe cancer care or diabetes, to really start to implement processes relevant to 717. How do you get the buy-in across different stakeholders?
Yes, Thank you for that question. Our buy-in started because of the tremendous number of outbreaks we had and our difficulty in stopping them. So there was an acute time period for, I think, almost every health department throughout the world during COVID. What we were able to do was to portray and then implement 717 as a tool that gave us a framework and a structure to monitor what we were doing and the impact of it, and gave us a goal that obviously, as you saw, we did not, and we still don't achieve everywhere. So this ability to implement, have a framework, use the tools that 717 has available, the early action, these ways that you can self-evaluate, enabled us to get buy-in. That buy-in was critical because, as you saw from what Beatrice said and what I said, this is in a sense, a community-wide initiative to understand what it means to detect, notify, and react to any outbreaks. The application for non-communicable disease is actually a space where we are going with this recognition, once again, that this is data-driven. It gives us a goal, it gives us a way to measure, and it gives us a way to hold ourselves responsible. Historically, there has not been a way that I am aware of to measure a public health department or a community response to outbreaks. By having that metric itself through the tool, it enables us to improve what we are doing. So engagement was initially difficult, but just like Beatrice, we worked closely throughout the department, and we worked with our community. Everywhere there's an identification of an outbreak in some congregate care setting or that affects the community, we remind people this is what public health does. This is the value of public health. So it gives us that opportunity also. Thank you.
It's wonderful. The next question is to Beatrice. Beatrice, over the years, you implemented 717, 2023, 2024, 2025. But as you continued to implement, you could start to see an improvement, particularly in the response part. Can you tell us a bit more about why you think response improved, meeting the response target improved over time?
When we implemented of the 717 response perspective of new events of city, we have observed that we needed to investigate the factors because our response rates were not throughout time, and investigated and realized that we had to create certain protocols when we've been investing. We've been needing to improve our surveillance team in the public health. We also understand that the increase of the response rates was just because of the investment we have been implementing. And not just because there's more events in the city. We believe this is a fruit of our investments, the quantification of the response, and the detection that we've been having opportunity of these events to realize that we've been getting a better result considering the investments that we have made during our surveillance team, the public health.
Thank you very much. We'll round up now because we are at time, but some really important themes have emerged. One is that, cities can use the 717 target to measure performance. But then cities can also apply 717, a wide range of use cases that are often unique to cities. So mass gatherings we talked about, long-term care facilities or institutionalized settings provide opportunities for cities to apply 717 in a manner that is really relevant to their needs. But then this other aspect of, as cities implement 717, they create communication platforms where performance can be discussed, bottlenecks can be identified, and improvement actions set forth. And then also use that to hold each other to account in terms of performance over time. And so it's really been a wonderful session today, listening to each of you. I want to thank each and every one of our panelists for preparing and presenting today. To all the audience, thank you for the questions that you have shared and your participation. As mentioned, we will be sending out presentations and additional information via email to all registered attendees. And one last thing, please look at our website. The 717 Alliance website is a treasure trove of information related to 717, and you can access our learning materials, success stories, and even our evaluation. So please go to our website and look at our resources. Most recently, we've launched an online training. If you would like to participate and really understand 717, you can go through the introductory course as well as the next phase of the course. And we look forward to continuing to interact with you as we proceed. So thank you once again, everyone, for joining us. We look forward to the next Global Learning Network. Have a wonderful day.